The are you guys an Epic institution, by the way? Or
We are.
okay, it would just frame how I word things. So
You can use BPAs and
yeah.
specific terminology. Good to let some people know what that means more generally, but
Yeah.
I think almost every
I've given versions of this talk using completely generic terms, and I've given it just using Epic slang. So I can fit in between. I was gonna just start off, and I'm not sure. I guess I didn't really get a good sense of who the audience was necessarily, but I was gonna start off with like 10 slides of just kind of general kind of talk about like research and why we want to talk about more perspective as opposed to observational stuff, and then the last
Mhm.
the bulk of it's going to be talking about ACORN, how we did it, how we embedded it in the EHR, and kind of like and all those things.
Yeah, that was really what I was thinking that would be the key thing. I think working all the above is very good. Most of this audience, they'll know that Epic is a thing. They won't actually know the innards of how to actually do anything. These are mostly researchers, right? They download databases, they do machine learning, they do whatever, right? They do analysis.
Okay.
And so I think, so most of the people here do mostly retrospective work. So I think that would be a good motivation up front. Like, that's all great to do, but eventually, if you want to know what happened, you got to do prospective. If you want to learn something, that'd be a good motivation. And then there'll be enough people bought in, like, we totally agree. Of course, it's better to do prospective. We don't know how to do it. It's just so hard to do that. And so you kind of tell your story of like, it's hard to do, but Dr. Qian can show you that it is possible. Let me show you how I did it. That would be awesome.
Yeah. Okay. That's a good framing. So I start off with a couple of definitions, and I'll speed through that, and then I'll get to observational versus prospective work, and then we'll move into talking about ACORN and how we did it. And I think what I added here was, yes, we did it one way in this trial, but here are other ways that you could do the similar step of the trial. So I think this will work. I think this will go well.
Yeah, it should go. Did you recently do? We were looking at the, some NIH pragmatic trials talk or something like that.
Yes, I gave it was not quite as in depth or in detail as the talk I'm about to give, but it was talking about this trial and a little bit about like EHR embedded clinical trials for the NIH Pragmatic Trial Collaboratory. I think that's what it's called.
Yeah. Great. I mean, it makes total sense. I mean, I'll sort of reference, back when I was a fellow years ago, it's like, oh, we should do more pragmatic trials, A/B testing in real time, let alone all the retrospective stuff. And it's like, yeah, it seems like a good idea. It was like, oh my gosh, there's so much red tape, so many barriers to actually do it.
It really is. I mean, I wasn't going to get there, but certainly we can talk about it now or talk about more after. I mean, I would love to just do this like 8 times over for things that are important to me as a critical care physician in the ICU. And there's one of the biggest barriers right now is like, do I have the time to do this 8 times over? Not the EHR, but once it's running, it's running. But like all this
Yeah.
and everything else, it's a lot. It's a lot, and so
I hope we make some space for discussion. It's going to give people some perspective on that, like, because a lot of the people here will be computational folks, not all, but most of them will be. So yeah, good idea. I can do the stats for you. You just run this randomization where it's like, good idea, and it's true. That is still a huge step from the basic concept to how do you get it actually working in a live environment. And I think that will be enlightening to hear a real story, but also actually I want to make it, because I think it's inspiring that as hard as it was, you were still able to do it. I kind of gave up on this type of thread years ago. Like, how many committees I gotta like convince you? Like, forget, I'm just going to do more retrospective work.
yeah, no, for sure, absolutely. I feel that. But now like I'm pot committed, so
yeah. I mean, you're in a great position, and the reality is, I think we should be building more towards what you've already achieved, and so the implications are much more real. I'll give you one little heads up, minor warning. That's not really, but one of our fellows right now, I think, wants to do some reanalysis of the ACORN data. He might ask the question. He'll say, basically, if you actually look per protocol, who actually got, how much crossover there was, your conclusions may not hold up. I don't know, just anticipate that. It would just be a good academic discussion. I think a lot of it comes down to whether or not you buy into intention to treat, which I tend to for a randomized study. But there'll always be somebody will ask you about some variation on it.
Yeah, no, that's fine. I think they've already reached out and we're like we're in the DOA contract process and all that other stuff.
It should be cool. It was more, we both thought that this is an awesome study. What it tells you is a very real and relevant question, but also how it was done. So just trying to understand it at a deeper level would be great.
Yeah, no, absolutely. Absolutely.
All right. If you want to grab a bathroom break or some water, now would be the time to do it. And we got a few minutes. We'll informally start in just a few minutes.
Yeah, absolutely.
There's always a lag. People are going to start piling in once the food starts showing up.
Yeah, no worries. None whatsoever. What do you do, Jonathan?
So I'm the Center for Biomedical Informatics Research. I mostly run clinical informatics data science research lab. I also practice internal medicine in the hospital.
So you're a hospitalist, or you outpatient stuff, or both, or?
Hospitalist.
Very nice. Very nice.
I actually like outpatient work in terms of I think broader implications for medicine, but compatibility with doing research is hard to do outpatient. There's always the in-basket message after that versus hospitalist, ICU. It's very intensive for that week or whatever. But I'm off, do not call me. I'm not hospitalist. Right?
Yeah, message basket. I mean, my wife does primary care, and she got a call like 11:30 last night. And I was like, not me.
Maybe you could try to compartmentalize a little, but when I was doing a little bit of primary care before, I would stress out. I have to check my in-basket like multiple hundred times. I'm worried there's some patient who's waiting for me, and I don't want them to be stuck waiting. It's just hard to walk away from it.
Yeah, no, for sure. Yeah, the message basket is just killer. One of my colleagues, cardio oncology, he's like a basic science 80/20 researcher. He does 1/2 day or 1 day of clinic. I don't know which it was. And he's like, the message basket just spills over. And message basket an hour a day, no matter what. It's like,
yeah, exactly. So even if it's the theoretical split. No, I'm basically kind of 80/20. Although some of that 80s, but there's research, but also we have our Stanford Healthcare Data Science team.
You really think so?
Which explicitly is not a research group. In practice, there's a lot of gray fuzz happening, but it's paid for by the hospital CIO, CFO, CEO, and that's to translate all this research or data science AI stuff into application. But that's really nice to have that conduit. Versus when you're a researcher trying to bring something like you're doing into the healthcare system, barriers you gotta walk through that are hard to get by into.
yeah, that makes a lot of sense.
Accurate.
Hi, everyone. This is Mark Newton, our division chief right here.
Nice to meet you.
Got this pizza and a salad, so I can hear a shuffle outside. So there's about to be a mob that's going to show up.
Great.
Where's the orange? I brought my own orange from Costco. That's what it takes to get some healthier food. I'll let the box of Ritz crackers. That's a backup. All right, let me put this down. I'll come back and we'll informally start in about 30 seconds just to kick things off.
I'm gonna have to leave about 40 minutes into your talk, and it's not because I'm disgusted by what you're saying.
Oh, no problem. Thanks for the heads up.
Highly objectionable results. Don't believe anything. I refuse to listen any further.
I will, I mean, I should be close to done with my slides about 40 minutes. So
Okay. Be good timing to aim for.
yeah, can't promise I will be completely done, but I should be close.
That'd be good. Some space for discussion will be good. I know we took this one. Yeah, there's like the 10 and people are grabbing their pizza right now, so I'll give them another 30 seconds. My individual space video. So the room a little bit. And for what it's worth, this is actually only half the room. You actually can't see there's another entire half of the room with people listening and watching. They're just off camera.
Yeah, great. It's fantastic.
We are already recording and people are shuffling in, and I see they're logging in online as well. Why don't we go ahead and at least informally start? Very glad today to have Dr. Edward Qian, calling all the way from Vanderbilt, I believe. Here to talk about some really cool, into the specific studies done, but more I think you're like how the study was pulled off, the implications of this type of study, I think are really captivating and something we should all strive towards. Before we dive into that, Dr. Qian, just tell us about yourself. Where were you born? Where'd you grow up? I mean, know what you are. You could have lived a different life, right?
Yeah, absolutely. Thanks for having me. This is a really great opportunity. I am from Maryland originally. I went to NYU for medical school, well before it was free, if you were wondering. I had to pay my whole way. And then I came down to Vanderbilt for my internal medicine residency. I stayed on for a pulmonary and critical care fellowship. I took a T32 research year, where I got a master's of applied clinical informatics during my fellowship. And everything we're going to be talking about today happened during my fellowship. The actual like submission and publication process spilled into my first year of faculty. But yeah, everything I did here was as a clinical fellow. So.
Was there some purpose in that decision? It sounded like most of your training was very clinical, but then what made you do this master's or this fellowship in informatics? Was that something that met your interest all along, or was this sort of some sort of pivot?
It's a little bit of both. It's a little bit of both. So the question we're going to be talking about, what cefepime and zosyn, was just something that bothered me clinically for the longest time. And I watched this change happen on my institution while I was training. For my intern year, it was all vancomycin, and then all of a sudden it was all cefepime. And between our neurologists and our ID doctors and nephrologists, we were just kind of being caught in the ICU as the war zone. Is like no zosyn, no cefepime, no zosyn, no cefepime. So it started there, and so I went to my research mentors when I was starting the research part of my fellowship. Like, this is the question I want to tackle, and they laid out to me all the ways that this question would be impossible to tackle. But laid a caveat. It was if you could integrate this into the EHR and randomize from the first dose, then maybe we could talk about it. And so I have some background in computer science and programming or anything. Nothing I really like planned to bring forward to medicine. But I was like, let's try this. Let's take the first steps and see if it's a real thing. And I took more steps and more steps and more steps, and before you know it, I was at another graduation ceremony that I didn't want to be in, sweating in a rented regalia and all that stuff. So.
Never stop learning, and I don't know how many board certifications you have to maintain now, but
Oh yeah, people are trying to convince me to get the informatics boards, but that'd be 4 for me. And I'm not sure I need that right now.
don't think you need it. I think you'll be okay. I say people we've got a relevant full room again. You can't see that room and more people online. I'd love to chat more here about that story, but I think we can go ahead and dive in. We'd like to go ahead and share your slides and take it over. I think a lot of great room for discussion on what led to this and how we should all think about everything we're studying and developing and building, because it has real implications.
Absolutely. Thank you so much. Do this. All right. So yeah, so thank you everybody for having me. We're going to be talking about informatics efficiency trials. As I had already mentioned, I'm a pulmonary critical care faculty. I have a secondary pulmonary anesthesia department for their perioperative informatics research team. And I think one of the kind of big things we have here is the Vanderbilt Center for Learning Healthcare, which is a kind of initiative saying like, well, we make all these decisions in practice. Well, can we get some more data and more to drive our decision making? On the bottom screen are my mentors. The first 3 are my clinical research mentors in pulmonary and critical care: Todd Rice, Matt Semler, and John Casey, who I owe a lot to. Just wealth of knowledge, want to share that knowledge and help me there. And then on the right is Adam Wright, who is the professor in biomedical informatics here at Vanderbilt. who came by way of the Brigham, who really encouraged me to kind of gain the skills to do this. And every step of the way was just a great encouragement. I have a lot of thanks for him too. So we're gonna first talk about 10 slides worth of just like why randomized trials compared to kind of the wealth of data that we have otherwise. And then we're going to dive a little bit into the ACORN trial, and we're going to dive really deep in kind of the methods and how we did this. So the first couple of slides are some definitions, and we'll go through these quickly. But the foundation of all research is the definition, identification of the cohort, who we're studying, the intervention, what we're studying, and the outcomes, what happened to the patients. And this is a kind of a simplistic view, but it really is important because when you're talking about like, okay, what defines our cohort, what defines our intervention, there's things like demographics and disease states, procedures, cutoffs, all of these different types of things can define our cohorts and interventions. And outcomes, a lot of those things overlap. A lot of these things overlap with our outcomes, but then clinical outcomes like mortality, hospital length of stay, cardiac events, kidney events, and so on and so forth here. You also, when you talk about research, you talk about retrospective and prospective. So retrospective is taking this point in time and looking back to see patients who already were fit your cohort definition. And prospective is looking forward. Who's going to fit my cohort definition? And really the big difference here is, well, in retrospective data, the outcome is relied on data if already collected, which may not be the best. It may not be perfect for what the study question you're looking for. Whereas prospective, you get a chance to define and dictate your outcomes and collect the data that you need to perfectly answer the question. We'll talk a little bit about this when we talk about ACORN, but just the concept of discrete data, which I think a lot of people here are familiar with, but just to make sure that we're all on the same page. On the left of the screen, I put out the kind of the definitions of cohorts and things you can use for your intervention and your outcome. On the right, I said, well, here's some discrete data. So these are things that are stored in a way in the EHR that you can just extract that out. You don't need any type of natural language processing or otherwise. So these things are like age and sex and zip code, diagnosis codes, procedure codes, lab values, medication administration records. The way I like to put this is these things exist in a box. And so if you could make an Excel document and fill out these things, then those things are considered discrete data. But you can imagine that there's certain types of demographics and outcomes and interpretations that aren't discrete data, but still might be important. And so these are important things to be thinking about. So observational versus randomized. Observational can be retrospective or prospective, and the intervention is not controlled. It's up to the clinician at the time. And so you're comparing one group to another. And randomized, you can only do this in a prospective manner. And the intervention is controlled. So you dictate the randomization, you dictate patient A gets therapy A and patient B gets therapy B here. And so y'all, I understand an Epic institution, and I'm not sure if you guys are familiar with Cosmos, which is just this. I mean, look at those numbers at the bottom of the screen. 220 million patients, 9.3 billion encounters, 4.5 billion face-to-face visits. Well, this is a wealth of data. If you talk about cardiology and you're talking about some of the biggest studies in the world, well, let's take this, for example, in critical care, we're looking forward anxiously for the MEGAROX trial, which is going to enroll like 30 or 40,000 patients. It's going to be the biggest critical care trial ever performed. There are 20,000 now. 20,000, I mean, 9.3 billion is just nothing at 20,000. So why not just use all this retrospective observational data? Well, there can be some issues with observational data. It can certainly be useful, but sometimes it can provide an incorrect answer. So it can be limited by confounders, right? So you might say, oh, drinking alcohol is associated with lung cancer, but really drinking alcohol is associated with smoking, and smoking is associated with lung cancer. And we try our best to limit confounders and adjust for confounders. Ultimately, it's hard to have and then account for every single confounder that could possibly be there. And randomization takes some of that away. And then there's limitations by indication bias. So since you're not controlling intervention, well, the clinicians decided to do one or the other for a reason. And that reason may be important and may be something that you can really adjust for necessarily or completely adjust for. And so here are a couple of examples of the same topic. And the first one is, well, after the adjustment for confounding variables, it found that patients had postmenopausal women using hormone therapy had a lower risk of death. And so that's great. Well, we could go ahead and put all of our postmenopausal women on hormone replacement therapy. But then this was studied in a prospective manner 5 years later. And it was said that overall, the health risks exceeded the benefits of the use of hormone replacement therapy in this patient population. And I won't get into some of the details of why they think that these are discordant, but there are several examples of this retrospective data saying one thing and prospective data saying another. There are many examples where they're the same, but we can't predict which ones are going to be the same and which ones are going to be different. So prospective randomized trials are our highest standard of evidence. And what I'm going to be here to try to convince you guys of is that we can use electronic health records to facilitate randomized trials. And so we're going to be talking about the ACORN trial. This was published in JAMA in October of last year. And the clinical question here is, well, sepsis is a problem. We know sepsis is a problem. 2 million adults, according to CDC in the US, experience sepsis each year, and 270,000 die before hospital discharge. And we know a cornerstone of treatment here is early broad spectrum empiric antibiotics. All the guidelines say it, but these guidelines don't give us any further direction. They don't tell us which antibiotic to use, and mostly because there's not a lot of data. Two common antibiotics used in this realm are piperacillin-tazobactam or Zosyn. I'll use those interchangeably, and versus cefepime. And so in the last 10 to 15 years, there was a lot of retrospective observational data that says, well, Zosyn may be associated with acute kidney injury, especially with concurrent use of vancomycin. And even so much so to the point that FDA has a black box warning on Zosyn saying, hey, your patient may develop AKI if you give them Zosyn. And so astute clinician said, well, I'm not sure I necessarily believe that. This is easy. We have another choice here. We'll just go ahead and use cefepime. And as we use more and more cefepime, we started seeing more and more of this phenomenon called cefepime neurotoxicity, which is a clinical syndrome that ranges a spectrum of presentation from coma to delirium to agitation to seizures. And FDA has a warning on cefepime that says if your patient has existing kidney injury, well, cefepime may be associated with seizures. And so we kind of get stuck here. At Vanderbilt, we had a BPA that said, hey, your patient's receiving vancomycin and pip/tazo for more than 2 days. Do you know what you're doing? Do you need to talk to ID? Do you need help? And so this was something that we were doing here at Vanderbilt that was pushing people away from pip/tazo, not specifically to cefepime, but a lot of our patients were being pushed in that direction. I can tell you from anecdotal in our clinical practice. So this is an example from one day on service. So our medical ICU, we have about 10 patients on a team. And so on my 10-patient team, we were using so much cefepime that I had 5 patients who had cefepime neurotoxicity. And I do believe cefepime neurotoxicity is a thing, but I don't think the prevalence is 50% of the ICU patients. And it's really quite incredible if you read into some of these notes. It says, well, we can't use cefepime, so let's start this patient on dialysis. Oh, well, we can't use cefepime. Let's use meropenem. And I don't know if anybody's infectious disease here in the room, but they might be puckering a little bit when they hear, oh, like, let's use meropenem because we can't use cefepime, we can't use Zosyn. But this is the reality of where we were from a clinical perspective. So our goal here was to conduct a randomized trial to understand the effect and the safety of empiric antibiotic choice on our patients in the emergency department and our ICUs. And the ACORN trial was a 2,511 patient randomized clinical trial where the randomization was the choice of empiric gram-negative antibiotics or piperacillin-tazobactam. And usually here, I would go into some of the methods and everything else, and I will get into that, but I wanted to take a quick break and mention, well, I boiled this down. I think the most quoted number here is 10, but boiled down, there's 5 steps to clinical trial. Can you screen for the patients? Can you enroll the patients? How do you apply the randomization and the intervention? How do you monitor the patients once they're enrolled in the trial? And then how do you assess those outcomes? And on the top right of the screen, I'm going to have a little bit of a banner to orient you to where we are in this clinical trial structure as we step through the ACORN trial, and we step through that in a little bit of detail. Like I mentioned in the past, like before, the ACORN trial was an EHR embedded pragmatic clinical trial, and this is the first step of the EHR embedding. So for a patient that met the screening criteria, and the clinician was initiating an order for cefepime or Zosyn, a BPA or interruptive alert would pop up that says, hey, this patient is eligible for the ACORN trial. Would you consider enrolling your patient in the study? Here are the specific inclusion and exclusion criteria. So you had to be an adult. You had to be in a participating unit. We didn't want patients who have been in the hospital for a long period of time and had a lot of different things happen to them in their hospital course. So less than 12 hours from presentation to the hospital. And then again, the treating clinician is initiating an order for either cefepime or Zosyn, and there's no allergies documented. The exclusion criteria are if you've already received more than one dose of cefepime or Zosyn. So this is your patient who was on outpatient Zosyn for some reason. They've already got 7 days of Zosyn. Well, we're not going to change them. If you have an allergy to cefepime or Zosyn or cephalosporin or penicillin, well, you shouldn't be randomized. Prisoners are a very commonly protected subpopulation in trial. And then you might be giving a patient cefepime or Zosyn for a particular reason. So if the clinician thought that cefepime or Zosyn was required or contraindicated for the optimal treatment of the patient, well, then they could opt out here. The reason different trialists will have different reasons that they put something as inclusion, something as exclusion. But the way we split this up here was that the inclusion criteria are all things that we can assess within the EHR with some degree of certainty. And the exclusion criteria are all things that I needed a clinician's input on, right? So age, location, time, and that you're starting an order, that's all within Epic. I can tell all those things. But if you're a prisoner, whether you feel like one of the criteria, if they got something at an outside hospital, I might not know those, and those are the exclusion criteria, and we'll step through that in a little bit more detail. So this is a little bit under the hood. So when you are building a BPA, it's some of the screens that you'll see here. And what you can see here on the bottom right of the screen is I put the inclusion criteria again here, and you'll see that the criteria that I'm using, well, you're located in the medical ICU or the ED, your age is greater than 18, you're less than 12 hours of presentation, you don't have an allergy, you're ordering Zosyn or cefepime. All these are my inclusion criteria, and this is what the BPA fires on. So this is my screening. And this is just highlighting that the trigger is that you are initiating an order. So this is the action in the chart that tells the BPA, yeah, let's go ahead and pop up now. Here are my exclusion criteria. And again, I put here the exclusion criteria to the study, which are all things that I cannot necessarily reliably discern from the chart. So I ask the provider, well, do I meet any of these criteria? Are they a prisoner? Are they actually, not an adult? Do they have an allergy because they have a new chart and someone just hasn't inputted their allergies yet, but they have an allergy? Or you require cefepime or you require Pitazo. So the ACORN trial was unique in the sense that all 5 of these steps that I'm talking about right now, we were able to embed in the EHR. But you can imagine that there are certain situations where you might not be able to embed all 5 steps, but you should consider and you should be thinking about, well, can I embed some of the steps? And so for screening, so let's say you can't enroll or randomize within the EHR, but you can utilize the EHR to screen. You can assign a flag. You can send a message to an enrollment coordinator, like an in-basket message. You can file something to a flow sheet row, which will then give some sort of trigger to somebody to be looking for. These are all ways that you can use the EHR to screen and apply these criteria and just run in the background without having someone to sit there and open up the chart of every new patient that ends up in the ICU. Even if you can't screen, can't do everything, you can still do these screening tools within the EHR. You might be wondering, is like, well, what about consent? And I think consent is a really important consideration here. And this is one of the big reasons why you might not be able to enroll and randomize within the EHR. And most trials do require traditional informed consent. Modifications of informed consent could be given in emergency conditions. This is a topic unto itself. And so I'm just going to talk about what we did in ACORN. ACORN was approved for a waiver of informed consent. And one of the criteria here is because they have to be impracticable and unethical. And so we know that our patients who have septic shock have a 7% increase in mortality for each hour you delay empiric broad-spectrum antibiotics. And so for us to say, okay, we found a patient and we're going to delay their antibiotics to go through the official screening process by an hour or 2 hours or several hours, that would be unethical. So we couldn't do that. And sometimes for our patients with sepsis are coming in with altered mental status, and we have to try to reach legally authorized representatives, and that's time even further. And so our IRB agreed, and ACORN proceeded under a waiver of informed consent. Randomization here happened within EPIC, and so the important thing is at the very bottom, and don't highlight that. No, the important thing is at the very bottom is that when the patient was enrolled, that we had an extension here that just saves a random number for the encounter. This was a simple coin flip randomization, and so it just gave me a 0 or a 1. And 0 was one arm and 1 was another arm, and it just was flipping a coin. The application of the intervention happened in an order set. And so this is again, under the hood order set, and you'll see that there's an ACORN trial order group for cefepime, and there's ACORN trial order group for Zosyn. And these groups were, and this is just a cefepime example, these groups only showed up if that randomization was 0 or randomization was 1. So you can see at the very bottom, there's a criteria that says ACORN 0. And the ACORN 0 says, well, if you're randomized to 0, then that means you're the only group when you opened up this smart set is going to be the cefepime group. If you were randomized to 1, when you open up this same exact smart set, you would only see the Zosyn group, and this is how the intervention was applied. There are a lot of clinical trials that use more sophisticated randomization than just a coin flip. This is something that we've been talking with EPIC about. How can we do this natively within EPIC? So block randomization is, well, you don't know where you are in the block, but you know that after every, say, 10 patients that you're going to have 5 patients in one arm and 5 patients in another arm. So your randomization numbers never get that far off. You can imagine if you're flipping a coin and you flip a coin 10 times, you might get 8 and 2, you might get 5 and 5, you might get 10 and 0. And so block randomization prevents that. Stratification is, well, I really, really want to make sure that my patients between my groups are balanced in a certain way. And so this is going to say, well, in this trial, you might have said, well, vancomycin was important. And so if a patient was on vancomycin, that I make sure that those patients are distributed equally between the groups. Currently within EPIC, we can't do either of those things, but you can export the information that you need to an external program and then import the randomization back. So there's still ways of doing these, but just not natively within EPIC currently.
Could you just repeat it? I think you just said it, but so where did the randomization have to happen? Isn't EPIC BPA has some built-in function or something? It's not by the MRN number, or where did it actually happen?
Oh, you're opening up a can of worms for me with MRN number. But we can get to that at the end. This is a separate BPA that pops up when the patient was enrolled, and the extension was that it saves random number here. So within EPIC, you have rules and extensions to do things that are outside of the normal kind of BPA framework. And this is EPIC's ability to allow you to be flexible. And so this is just saying that when this BPA pops up, and it's a silent BPA that runs in the background and nobody ever sees, when these criteria are hit, then this extension is going to flip a coin and then save the 0 or 1 to a data element to be used in the future.
Okay, go ahead.
One of the important pieces of running a clinical trial is the monitoring, and especially monitoring for safety events. And so this was a BPA that said, okay, well, hey, you want to continue to use cefepime-rosocin, that's great. The patient has already been enrolled. They've been enrolled to either the cefepime or the Zosyn arm. If you don't have an issue, can you continue them in their arm? Can you continue to use cefepime? Can you continue to use Zosyn? But if you don't, that's perfectly fine, clinician. You can do whatever you think is best for the patient, but tell me why. And some particular reasons are, well, is there an allergy? Is there a non-allergic drug reaction? Is something come up in the last several hours when we're reordering the drug that tells me that an alternative is superior that wasn't known before when they were randomized? And all this is okay. We just wanted to know the reason. This is a similar one for when they are or when they're reordering. And so this was all monitored on the back end. This is if you're discontinuing the drug. Again, are you discontinuing for de-escalation, escalation, you don't think there's infection, or you think an allergy? And all clinical trials, you need to talk about your safety outcomes and your adverse events. Are you causing harm? And when you're talking about antibiotics, the biggest harm that you think about is allergy, not the chew kind of allergies in the clip art, but these drug allergies, anaphylaxis, hives, and such. So I had a report that I ran every day that was looking at the reasons that clinicians had clicked around and said why we're changing the antibiotic use, why we're not continuing on in the trial. And if they gave me an allergy or a non-allergic drug reaction, that's a chart that I would follow up on and make sure that was this just a get this BP out of my face, I'm just clicking anything to get through it, or was this truly an allergy that I need to figure out and report to the IRB that we had an adverse event in the trial? Another way that, I can only trust clinicians so much. And so another way that I was monitoring the trial was I was actually had a report that gave me the patient's allergy list. And so none of our patients should have penicillin or cephalosporin allergies. So on the far right column, if they gave me, well, look, they have a penicillin allergy, I'd be like, what happened here? And so those were other things that I could follow up on. The rest of this report is just me keeping an eye on the fidelity to the intervention. And so this is making sure that patients in one arm were staying in the arm that they needed to be in. So the 0s and 1s you can see in looks like the third column here. The 0s are cefepime. And so you can see that the 3rd and 4th and 6th patients were assigned to cefepime and received cefepime. The 5th and 1st patients were assigned to Zosyn and received Zosyn. But that 2nd patient was assigned to Zosyn that has a little 1 in that 3rd column, but received both drugs. So this is a patient that I, again, would follow up on and say, what's going on here? Is there a reason, or should I contact this team and see if they could switch back or otherwise? So this was kind of monitoring and making sure that the trial was going well. Our primary outcome in the ACORN trial was AKI on an ordinal scale between enrollment and day 14, where 0 is no AKI. Ordinal levels 1, 2, or 3 were stages 1, 2, and 3 AKI by the KDIGO creatinine criteria. And we felt that death was worse than any stage of AKI, so that was assigned an ordinal level of 4. We looked at major adverse kidney events as a secondary outcome. And then we were also concerned about this neurotoxicity, so we also specified a key secondary outcome of days alive and free of delirium and coma, where delirium was defined as a positive assessment on CAM ICU, and coma was defined as a RASS value of -4, -5. And you'll notice that I've highlighted some of these words red and underlined. Well, these are all the pieces of this outcome. The creatinine values, dialysis, death, CAM ICU, RASS, and our outcomes were all determined by discrete data that we were talking about before. The creatinine is a lab value. If you get dialysis, you have a flow sheet value. CAM ICU and RASS are stored in the flow sheets at Vanderbilt. If a patient dies while they're in the hospital, then that's recorded. So all these things we'll be able to extract it from the EHR on the back end. There are other ways of getting discrete data. So you might say, well, the data that I need are from a provider's note, their smoking status or their or something from that perspective, and there's no form or way in Epic to do that. And so there are ways of doing that if you want to be thinking about it. This is something that I built for our COPD group and our COPD registry. That every time that they see a patient, they go through and flip through these smart lists that allow them to collect values, and these are things that they said they collect anyway. But now on the back end, if they want to say, well, Eddie, I'm interested on how many of our patients have resting hypoxia. Well, I can go ahead on the back end and look at that specific data element. I can tell them how many and who they are, and if they want to do some research on that, then they're able to do this. This takes a little bit of agreement. Our COPD group is only four providers now. And so they all agreed to do this every single patient. So I have a high fidelity to this data. But it is something that you can think about. It's like, well, don't give up if you think that the data that you need is only available in the text of a note. If you want to set this up, then this is something that could work. It's always important, I think, from an informatics side to think about who's going to interact with your clinical decision support for these BPAs. And so there's a lot of outreach here, and I won't spend too much time here, but general surgeons, emergency medicine, internal medicine, different levels, house staff, APPs, attendings, medicine subspecialties, so many people interacted with this alert. And so we had to do a lot of outreach before the trial started to say, hey, you're going to see this in your clinical practice. This is what it means. Feel free to make your own decisions, but this is the reason why we're doing it. We hope you agree, and we're trying to gather some data. And so just if you're thinking about doing something about the outreach beforehand is really, really important. So like I said, this trial was published in JAMA in October of 2023. And so we'll talk about the results here really quickly. This slide is our fidelity intervention. And this slide really demonstrates that the randomization through the EHR really worked. The vast majority of patients assigned to receive cefepime, and the vast majority of patients who were assigned to receive Zosyn. And so I was really proud of this. This is something that I want to get framed and put up in my office. Our primary outcome was new or worsening AKI by day 14. And I won't read all the numbers here, but as you can see on the odds ratio that there was no difference in AKI between the patients who received cefepime and Zosyn. Odds ratio is 0.95 and 95% confidence interval that crosses 0.80 to 1.13. This was our effect modification of the primary outcome, or a forest plot. And the thing that I want to point out here is that our subgroup of vancomycin, so it was thought that vancomycin was on the pathophysiologic pathway between Zosyn and AKI. In our subgroup that received Zosyn, there was likewise no difference in AKI in that subgroup. I didn't emphasize this, and I probably should have. We enrolled patients really quickly. There was 2,511 patients enrolled in 11 months. So that's about 8 patients a day, 7 days a week, 24 hours a day, over the course of 11 months. And this was really quick. And so we had, our original sample size was, 2,000 patients. And our DSMB said, well, vancomycin is so important to this question and you're enrolling so well that why don't you increase your sample size to see if you can power that vancomycin subgroup for your primary outcome. And so we were actually powered in our vancomycin subgroup to detect a difference, and we did not detect difference. For our secondary outcome, we likewise didn't see any difference in major adverse kidney events in 14 days, a mean difference of 1.4%, and that difference spans -1% to 3.8%. But we did see a difference in delirium and coma-free days. Odds ratio here is 0.79, ranging from 0.65 to 0.95. Free days outcomes are really common in the ICU, but aren't common elsewhere. What this is saying is that this is the number of days that you're alive and you do not have this outcome or this state. So days even free of mechanical ventilation, vasopressors. And what you want to see here is that you want more days free. And so what this is saying that there was fewer days free of delirium and coma with cefepime, or said in another way, that we saw more delirium and coma with cefepime, which was consistent with the hypothesis. So for the end of the trial, we say, well, compared to cefepime, Zosyn did not increase the incidence of AKI, but when compared to Zosyn, cefepime may decrease the number of days alive and free of delirium and coma. But from a talk perspective, I really hope that I highlighted for you all that one, that prospective randomized trials are the highest standard of evidence, and then that we as informaticians can initiate clinical questions or aid in clinical trial design by embedding pieces into EHR to streamline the trial conduct. And so, like I said, I already thanked my mentors already on the first slide, but there was a whole team behind this, the ACORN team, all the house staff and emergency medicine house staff that participated in the trial, enrolled patients, and very thankful to them. The Pragmatic research group have a lot of thanks to, and then the Center for Learning Healthcare for all their project management support, all the biostatistical support to really make this a reality. I have a lot of thanks here. This was actually from last week. We were out west, not quite as far as Stanford. We're in Utah, and this was before we're hiking through the snow, and then there's what could only be best described as a blizzard hit. We got a nice picture before that happened. So, well, thank you guys for your attention. And
All right. Fantastic. Well, thank you, Dr. Rob Gallo online. Did you want to go ahead and ask a question, comment? Go ahead.
Yeah, thanks so much. This is just a really, I think, awesome study, really inspiring to me as a, clinician, budding clinician informaticist. I did want to ask a question about the main outcome. It seemed like death and AKI kind of trended in opposite directions, which, can be a problem for ordinal logistic regression. You get violations of the proportional hazard or proportional odds. How did you all think about that, and what were your discussions about that? And then also I thought the subgroup without sepsis was kind of interesting, and I was wondering if you had any thoughts on why that seemed different from the sepsis subgroup.
yeah, no, those are both great questions. The first question was asking about the AKI and death and the competing risk of death and how we dealt with that. And I didn't present it in the slide. In our supplement, when we saw that, we wanted to kind of address the concerns that you're bringing up. So we did a fine and gray analysis, which I'm not a statistician, so the details are a little bit lost on me, but it was looking at the competing risk of death. And the fine and gray analysis showed that that there was still no difference in either AKI or death when you're kind of separated them out. The second question was looking at the sepsis subgroup, so the lack of sepsis subgroup, and if there was a benefit or there's AKI seen. I'm not exactly sure. This is I made a big effort to talk about the vancomycin subgroup and that we were powered there, because one of the things that we're always taught with clinical trials is that subgroup analyses should be hypothesis generating, but ultimately are underpowered to make definitive conclusions. There's a lot of examples in our own work that we've done here at Vanderbilt where we did a clinical trial, we had a subgroup that seemed interesting and seemed plausible. Then we do a clinical trial around that subgroup, and then ends up being no difference, and it would end up just being kind of a type 2 error. So I don't really know there. Otherwise, and I would interpret I would interpret that with caution.
Great. I see Kate Miller's got a virtual hand raised. Do you want to ask a question?
Yeah, thanks so much. Can you hear me?
Yeah, go ahead.
Great. Thanks so much for this talk. I am actually working with Maya Wyadom, who came from the Vanderbilt ED. I don't know if you know her or not, but
Yeah.
anyway. Oh, great. Yeah, we're doing something quite similar with building in a BPA. So I really appreciated all the information about the guts of how, the BPA worked in EPIC.
Right.
So I'm a biostatistician. From a clinical trial design standpoint, I totally love this model, but what I'm most worried about is balance between arms. So I wonder if you, two questions. One, I wondered if you've looked at the balance between arms. For example, maybe more people get enrolled during the day than at night because there's fewer staff at night and people are stressed out. I don't know. It could be that there's differences in the population. Although that's not a very good example. But I wonder if you look at balance. And the second thing is, I wonder if you looked at specific providers. Like, I could imagine there's a range of interest in the clinical staff, and some people are excited to randomize everybody they see who they can, and some people just say no automatically. And I wonder if that introduces anything. I guess actually the question is representativeness of these among the people who are not enrolled. That's what it is.
Yeah, no, that's a great question. I think the second question is a little bit easier for me to answer, so I'll answer that first. I am fairly comfortable that the results are generalizable to a general population. I didn't show the consort diagram, but most of the patients had a reason for requiring cefepime or Zosyn, either an allergy or they had a prior culture result, or Zosyn doesn't penetrate the CNS, and so they wanted to use cefepime. So on and so forth from that perspective. But I think what's really important here is that there's a real kind of culture at Vanderbilt of trying to get the best data to drive our clinical outcomes and clinical care for our patients. And so I think one of the things that was really the most surprising and one of the kind of like the feathers in my cap as an informatician was when we stopped the ACORN trial. I had ED providers come up to me. I was working clinically, walking through the ED, and they said, "Oh, you know what? I really miss that BPA."
Oh, no, you did not. That's
Yeah.
unbelievable. Wow.
They said, "I really miss it because now I have to choose. I have to decide." Your BPA was so easy for them to decide that they're on empiric prospective antibiotics and the BPA would choose. So, I mean, clearly the ED loved it. Our ICU was on board, and so I don't have a lot of concern from that perspective. Your first question was a good one. So you're talking about, did we look at differences in time, like when patients were enrolled? I don't know. I don't have the answer to that question per se, about when patients were enrolled. Anecdotally, I know that a lot of our patients kind of come through the day and they have a big backlog in our waiting room and they don't get seen until kind of late hours of the night. But
What about just balance between arms, just on, demographics or whatever?
Yeah, if you're just talking about like the comparison between groups for the demographics that we collected, there was a good degree of balance. There was, like, when you're talking about like subgroups of source of infection, they might have varied by like a couple of %, but nothing that really seemed to have dropped to that would have driven the outcomes.
Interesting. Thank you so much.
Yeah, absolutely.
Maybe any questions in the room? Otherwise, I've got several.
I see one in the chat really quickly.
That's Rob again. Do you want to follow up?
Yeah, I can. So the question is, do you have a sense of the cost of the trial compared to what it might have cost if it was not embedded in the EHR? Yeah, this is a question that I answered for our hospital admin yesterday. So I'm prepared. There's some hidden costs here, I think, certainly. Between the support from the Vanderbilt Institute for Clinical and Translational Research and Learning Healthcare System, the support they gave me, like their funding comes from somewhere. But my support, the actual dollars to paper, was only my fellow salary that was supported on a T32 training grant. So I won't get into the details of my fellow salary, but it wasn't a lot. When you're talking about a clinical trial industry, you're talking about $20,000 a patient per se. And so this 2,500 patient trial would be running in the $10 to $20 million range. And I recently saw a paper, it was a tweet about a paper, I think it was like orthopedic VTE prophylaxis after orthopedic surgery. And it was a great study. Kudos to them, but the tweet was like, oh, like we enrolled all these patients thanks to this $10 million grant from the NIH. And I sat there, I was like, wow, I really wish I had a $10 million grant from that.
Imagine half of that was paid through your fellow salary.
Yeah, yeah, I really wish I had $10 million, period. From anyone, if anybody in the room wants to give me $10 million, I'm happy.
Yeah, even 7 years ago, the average cost for one randomized controlled trial is over $15 million. So that's not strange at all. Samson, too, do you want to jump in?
Yes, it is wonderful that you can conduct this trial using these electronic medical record. Now, can you sort of summarize all the kind of services that are required from the EHR for you to conduct this service? And also, second question is, we compare doing this trial this way, compare with using some other trial management systems such as REDCap. Thank you.
Yeah, so the first question is, well, like what did we have to do to get this built into the EHR? And that's a good question. Epic has a physician builder program, which I didn't highlight there, but I got training from Epic to be able to build order sets and build BPAs. And Adam Wright, who I had mentioned before, was instrumental there. If I had any issues or questions, or there was a specific step that I wasn't sure about or didn't know how to do, he would help me there. But I think one of the keys to the success of the ACORN trial was that I was able to build all of this stuff. I was able to extract the data from the EHR on the back end. And so from that perspective, so that was great from that perspective. From a governance side, we have a clinical decision support working group who approved all new interruptive alerts and clinical decision support changes. And so this had to go through that. We had a research informatics group and had to go through that. So there was some degree of governance that we had to go through, but nothing that I would consider a huge barrier per se. It was more a hoop to jump through. The other question was, well, could you do this data management in REDCap? And we did do some of the data management in REDCap. So there were certain things that I couldn't reliably capture within the EHR. So the suspected source of infection was really important. So was it a pneumonia or intra-abdominal infection or a skin and soft tissue infection? And so when patients were enrolled, that me, or it was mostly me, but one of my colleagues would also hop into the chart, look to see where the clinicians thought that the source of infection was, and we jot that down in a REDCap, and we collected a couple of other values there that I won't get into all the details, but we used both. We utilize both.
So one of the, Adam Wright tweeted specifically that one of the key successes was that like you yourself could get into the physician builder system and do these things. Like for Stanford, even though I've gone through a physician builder training program, they won't actually let a physician actually do these things. We can learn about it, but we still got to find an analyst who will actually do it. And you have a maybe bi-weekly meeting. And anyways, it's just different.
Yeah, I mean, there's one thing I presented a couple of different informatics departments since ACORN was published, and that's what I'm hearing is that things are run differently. So I have an analyst, and if I have a question, I'll ask him things about that. And he has to do the official move from the training environment to the production environment. Like they don't trust me to do the actual moving. But effectively, I'm just building things. If I have a question, I ask him. I will kind of test things through with him after I've built it, and then he'll raise any other concerns that he has from his perspective, and we'll fix those, and we'll go from there. Like, and it's really, I think, imperative for these things to be able to make these changes or have someone who's dedicated to making these changes. We launched a trial yesterday, and we discovered that one of the criteria wasn't working perfectly. And so this morning I spent an hour or so figuring out what the problem was, fixing that, and now it's already fixed. So.
Very cool. I mean, imagine you can kind of rapidly prototype even the construction of some of this stuff versus here, like some of my team said, well, they'll email the guy and then they'll email us back. And trying to like debug code through a 1 week turnaround is very hard to do. Maybe some broader philosophical questions. What do you think? Because we had a similar thing at Stanford, like just I saw that BPA you had at the very start. Hey, vanc-zosine, you sure you know what you're doing? Maybe you should stop doing this, doctor. We also at Stanford several years ago, we used to vanc-zosine everybody, and then they said, stop doing that. Vanc-cefepime is better because you guys are causing AKI. I'm like, really? Okay, and you've kind of arguably proven that was all untrue, but policies are still happening based on potentially questionable evidence. Is that a fair appraisal, or is that okay? I mean, what are you just feeling about that whole progression of evidence versus practice?
Yeah, I think we always try our best. And I think one of the hard things is that not every question can be randomized. If you have something that the event rate is so rare, you'd have to enroll hundreds of thousands of patients to start to detect a difference. If you're talking about something that might cause harm, right? Like I think that this drug will hurt people. Well, no one's ever gonna randomize that. People want to help, and so it is really hard. Our BPA came from a good place and is what we thought was best with the data that was given at the time. But the ACORN trial was published, which is a stronger level of evidence than the prior data. We removed that BPA. We're in the process of repurposing it to be a little bit more of like, hey, like you're generally on empiric broad spectrum antibiotics for a long time. Like, would you consider about de-escalating, or do you still really need that? So it's taking the same BPA and repurposing, changing the language a little bit, not pushing someone one way or the other. But yes, this is so hard. It really is hard because as much as we tout evidence-based medicine, so many of the decisions that we make day to day are at best evidence adjacent. So.
Yeah. Following in that thread, then a lot of people, including this room, we big data analysis. We use propensity scores, observational data. We'll do all sorts of stuff, right? And you can do a lot. I think we're showing that actually, when you should still just prospectively study these things. You're showing it's possible to do it a lot of the time, but a question has to have some certain properties to make even this framework possible. You alluded to some. Right, there's got to be some equipoise. There's got to be some existing standards that you're comparing. You can't have too rare or too long distance in outcome. Like me, Robert's brains, I don't know, maybe lactator rigors and normal saline. I don't know, Lasix versus Bumic. Right? There's probably many to come up with, but what are the properties? I don't know if you've thought about this that a question needs to have for this framework to be feasible.
Yeah, I think that's an interesting question. I think I would I'll answer the question, but I also want to say up front that I had someone approach me about a year ago who'd known we were doing this trial, and it's like I want to do a trial like this, and like this is the question I'm interested in. I think it's the opposite. It's you want to figure out what's a good question, and then you want to figure out the best way to answer that question, and that might be an EHR embedded trial. I'm not trying to sit here to convince you that every question needs to be this way. So for example, a trial that's very nursing protocol driven. Well, a patient comes up to sepsis and we're going to randomize them to a protocol where they give less fluids and where we give more pressors to a protocol where we give more fluids. That's going to be really hard to put into the EHR. That EHR is not the best way to run that trial, and that's okay. So I think that's my tangential answer to that question. I think that it all really does start with the question, and what you want to be thinking about is, well, where do you see variation in yourself, in your colleagues? Are you and another service at your hospital taking care of the same thing differently? And then there's a lot of equipoise, and I think that's where these questions start. I think one of the ways that I know Stanford is a teaching institution, that if I'm attending on a house staff team and the house staff presents to me a plan on rounds, and I would have probably done a different way if I was deciding it, but I think about it and say, well, your plan is also reasonable. That's just different. Well, is that a question that we should look at? We should answer. We should be looking at. And so that's kind of like my gauge of like what clinical questions are important to me as a clinician.
I wonder if it's a follow-up to that one. Then when here was the secondary question, neurotoxicity, maybe we get away with it in practice, like, well, we're not sure which ones to choose, maybe because it doesn't really matter. So who cares if we just randomly, arbitrarily do it in practice? Why do we even need to answer the question? Obviously, I don't actually believe that. Well, how do you motivate again, like which things are worth going after?
I missed the actual question part of that. I'm sorry.
So if your resident proposes a plan, you're like, I wouldn't have done it that way, I guess I don't have a strong reason to say no. Maybe the reason we don't study that is because it probably didn't matter, whether you did it one way or the other.
Yeah, but I would argue you don't know. You don't know that. And so yeah, there's certain, like, I think you're alluding to a good point. There are certain like either or decisions here that nobody's interested in and nobody's going to study, and that's perfectly fine. But I think if you think about it a little bit more, you will find that there are some questions that might be important that either that maybe you'll always do it a certain way, and that's perfectly fine, but you see online or you at a conference or you're talking to somebody, talking to a colleague, and they do it a different way, and they're not wrong. Like, you know, just because you do it one way doesn't mean that you're right. And I think as a clinician who also is interested in research, having that mindset as I go about my day-to-day really highlights to me that, wow, so many decisions I make, I do with not the greatest evidence. But I make these decisions because I think that they're the best. I wouldn't do anything I think is not beneficial to my patient. But we don't have a lot of evidence. We talk, people talk all the time about this explosion of publications, evidence, and otherwise, and I'm sitting here in my clinical practice and I'm like, I'm making hundreds of decisions a day, and only some of them do I have good evidence for.
Can we squeeze in one more line of question? Mary Goldstein, either, do you want to get your credit, and then we'll probably wrap up from there.
Okay, sure. First, that was a great talk, really great study. Thank you for the presentation. So I have a question that really goes a little beyond the study, but about the application afterwards. Like, suppose you said, well, we would like to continue some intervention in the EHR in which we are recommending the preferred drug here. And when you conducted your study, you very carefully, as part of it, monitored daily what was happening with the drugs. And you actually reached out to some people. I think you said that you sometimes reach out to them to see what was going on or something, and used it to monitor that you were making sure the intervention was being delivered correctly. And so whatever is done during an intervention kind of becomes part of what was the intervention that was shown to be effective. And so I'm wondering if you were to do a kind of a routine care, move out of research into routine care to provide advisories along these lines, do you think you would also need to continue to have that monitoring by a very experienced physician such as yourself, who would watch what's happening and potentially reach out to people?
Yeah, that's a really good question. So if I can repeat that back to you, the question is, well, you say your intervention is this EHR intervention, but part of it was that you were keeping a close eye on things and making sure that the fidelity to intervention was there. I think that's a very good question. I think that I think that's a very good question. I think in this case, if you in this case, I would say that it happens so infrequently that I wouldn't think it would be a lot of kind of bang for your buck if you ended up doing something like that. But I think we only have a minute left. And so can I leave the group with a really provocative question? The first question from Mary was, well, I wanted to start an intervention here that where you are pushing someone to one way or the other, what would you do? I would argue that I don't know that for any given individual. I think one of the biggest takeaways from the ACORN trial is that this risk of AKI with Zosyn is probably not there for patients in general. And there's a risk of neurotoxicity with cefepime, potentially more so, but again, there's a secondary outcome. But I don't know for any individual patient if there is a benefit to Zosyn or cefepime or otherwise. And so I think one of the places that we need to be moving as a field is figuring out what happens for each individual patient. So I'll leave it at that.
Wow,
All
thank
right.
you.
Yeah, thank you again, Dr. Shan. It was a great discussion, and hope we'll follow up more because it was a great bit of work. Thank you again.
Absolutely.
Take care, everybody. Catch up again next week. All right, thanks, everybody.
Should I sign off now or?
Yeah, you can sign off. I just gotta. Great to see you.